Thank you very much for the invitation. I'm delighted and honored to participate in this colloquium series. I'm Mrs. Podal. I'm a clinical hematologist and a bone marrow transplant physician, and I work in Civil Service Hospital, Kathmandu, Nepal. In the coming 30 to 40 minutes, I'll be discussing about challenges in blood cancer treatment in Nepal. Let me start with the country introduction first. Nepal is a tiny country sandwiched between India and China and known to the world because of Mount Everest and its unique triangular national flag. Nepal has 8 out of 14 mountains in the world above 8,000 meters. Nepal is very well known for the beautiful lakes and its wildlife, and Nepal is the birthplace of Lord Buddha. Nepal has a population of 30 million people spread over 147,516 square kilometers. Kathmandu is the largest urban center in Nepal and is the capital city of the country. Although a small country in terms of area, Nepal is home to 126 different ethnic groups speaking 123 different languages. Talking about economy, literacy and life expectancy, 25% of total population lives below the poverty line. Its literacy rate for population above 5 years of age is just under 66%, 75% for males and 57% for females. The life expectancy at birth is 70 years, that is 68 years for males and 71 years for females, according to the recent World Bank data. GDP per capita is below $1,200. The healthcare system of Nepal is overwhelmed with infectious and communicable diseases. Nepal spends 5.8% of GDP on healthcare cost. If you compare this with the Western world, it is very low. But if you compare it with the neighboring countries, it's not that bad either. Although the health insurance program has been introduced in Nepal long time back, the national coverage is very low. Therefore, patients are bound to pay the healthcare expenses from their pocket. It is estimated that there are 50,000 to 70,000 new incident cases of cancer per year. Cancer stands as the third most common cause of non-communicable disease death in Nepal, accounting for 9% of total death. Lung, cervical, breast, stomach and colorectal cancers are the top 5 cancers according to Global Oncology 2020 data. This is a recently published data of trend of cancer incidence, mortality and disability adjusted life years in a cancer patient, and as seen in this slide, the incidence and mortality of cancer patients is increasing every year. So talking about burden of hematological malignancies in Nepal, this is a data published from Civil Service Hospital, and you can see acute leukemia tops the list. The acute leukemia is followed by essential thrombocythemia, polycythemia vera, chronic myeloid leukemia, multiple myeloma, lymphoproliferative disorders, myelodysplastic syndrome, non-Hodgkin's lymphoma, amyloidosis, and Hodgkin's lymphoma. So what are the challenges that we face while managing hematological malignancies in Nepal? So number one challenge is the shortage of healthcare workers. We have very few hematologists, very few hematopathologists, and very few nursing staffs who are trained in hematology and oncology. We have very few diagnostic centers are equipped with flow cytometry, immunohistochemistry, molecular and cytogenetic services. We not only lack dedicated healthcare workers, we also have a shortages of helping hands in our medical field. For example, we have a very few trained biomechanical engineer who can handle our instruments. We had a very bad experience few years back when our HEPA filter system broke down. Our local engineers were not able to fix it, and therefore we had to call engineer from Singapore to fix our HEPA filter system. Another challenge that we face in our day-to-day practice is unavailability of medicines. Our pharmaceutical company does not manufacture chemotherapy and high-end antibiotics. All chemotherapy and most of the antibiotics are imported from India. At times, there are shortages of chemotherapy because of strike, political instability, and various disputes in the border areas. Shortages of blood product is another challenge. This is because we have a very small donor pool or donor percentage. As per international standards, blood donor population must be 1 to 3% of country's total population to meet the demand of blood supply. In our case, it's only 0.5%, and therefore we have a frequent shortages of blood products for our patients. Another challenge is the lack of cancer centers. Most of our treatment centers are located in big cities. Therefore, people are bound to travel a long distance to visit cancer centers. Because they need to travel to different cities, they must rent a place to stay during the treatment, which adds cost. And on top of that, low health literacy and favor of alternative medicine and traditional healers leads to delay in diagnosis and results in poor outcome in our patient. Antibiotic resistance is a major problem in this part of the world, and this is primarily because of lack of antibiotic stewardship. This is our study of antibiotic resistance pattern in patients with febrile neutropenia undergoing chemotherapy in our center, and our study shows the high incidence of multi-drug resistance and extended drug resistance in our study population. In our study, 66.7% of total gram-negative bacteria were multi-drug resistance. Similarly, 33.3% of gram-negative bacteria were extended drug resistance, and most of the Klebsiella and E. coli were multi-drug resistance. Fungal infection is another challenge. There are reports of high incidence of fungal infection from Asian countries. Recent Indian study reported a high incidence of fungal infection despite use of posaconazole and voriconazole as a prophylaxis in hematological malignancies. And our own study using fluconazole as a prophylaxis for acute myeloid leukemia reported a fungal infection of 65%. Financial toxicity is a major challenge for us. This study was carried out in our center to define financial toxicity in acute leukemia patients. We used 3 parameters to define financial toxicity. Number 1 parameter was asking for the charity from public, and this was present in 94% of our patients. Number 2 was borrowing loans with interest from friends and family, which was present in 88% of our patients. And number 3 was the selling of property, and which was present in 87% of our patients. If 2 out of 3 parameters were present, we defined it as a severe financial toxicity, and it was present in 96% of our patients. Similarly, if all parameters were present, it was defined as extreme financial toxicity, and it was present in 73% of our patients. This survey describes the gravity of financial toxicity in our patient, and this is not a good sign at all. Diagnosis of hematological malignancies and out-of-pocket expenditure for treatment puts patient in lots of stress. We did this study on our patient using NCCN distress score, and to our surprise, 100% of our patients had experienced some form of distress. There are challenges, but that doesn't mean that you have to give up your aim or give up your hope. And as rightly said by Michael Jordan, obstacles don't have to stop you. If you run into a wall, don't turn around and give up. Figure out how to climb it, go through it, or work around it. So, despite these challenges, we are moving ahead with a determination to improve the outcomes of our patient. And one should thank Civil Service Hospital for its contribution for the development of hematology service in the country. Civil Service Hospital is the only center to have a comprehensive hematology and bone marrow transplant facility. At present, Only and at Civil Service Hospital is the only center to run 3 years fellowship program in clinical hematology and bone marrow transplant. And now Civil Service Hospital is regarded as a tertiary level center for blood related disorders. And things are improving. As you can see from this slide, on the left is a publication from Pediatric Hospital in 2014. They reported the outcome of pediatric patients treated in their center, and in conclusion they wrote their 5-year complete remission rate was 28.3%. On the right is a data from Civil Service Hospital, unpublished but awaiting a publication. This is a data of pediatric and adolescent ALL patient, and you can see that 5-year survival is above 85% for these patients. Similarly, things have improved for acute promyelocytic leukemia. In the past, patients were dying because of lack of treatment and diagnostic facility, but now 5-year survival of a patient treated in Civil Service Hospital has reached above 90%. So these were possible because of improved level of care and improved supportive care. So how to overcome the challenges? So I strongly believe by doing research or studies that can address our local problem can help us in many ways to overcome our challenges. For example, until recently, only 3 antifungal agents were available for treatment of fungal infection in Nepal. It was plain amphotericin, liposomal amphotericin, and injection voriconazole. Liposomal amphotericin and voriconazole were very expensive, and that's why we were left with no other option than to use plain amphotericin for our patients. Plain amphotericin is known for numerous toxicities like chills, fevers, rigors, acute kidney injuries, and many other adverse events. Therefore, we decided to make our own liposomal amphotericin by mixing a plain amphotericin with intralipid. Intralipid is a lipid that is used in total parenteral nutrition, and to our surprise, it worked. It reduced the infusional toxicity when you compare it with the plain amphotericin, and on top of that, it decreased the incidence of fungal infection and reduce the mortality of the patient. So you can see here in a fluconazole arm, the fungal infection was the rate of fungal infection was 65%. So in our amphotericin arm, with our lipid with plus amphotericin arm, we can see it has decreased to 21.8%. And you look at the mortality in lipid amphotericin arm is 0, but the mortality while using fluconazole as a prophylaxis in AML patient was up to 15%. And this slide shows the 20 days cost of our own lipid amphotericin, and you can see it is very cheap compared to a liposomal amphotericin and voriconazole. Another way to overcome our challenge is not by copy pasting. Is by not copy pasting and blindly following foreign guidelines and treatment protocol, and we have learned this from our aplastic anemia patients. We all know that ATG plus cyclosporine is a treatment option for severe aplastic anemia patients who are not eligible for bone marrow transplant. And if you follow the Western literature, the response rate of ATG plus cyclosporine in both pediatric and adult population is above 70%. However, our studies showed a different result. In an adult population, the response rate was above 70%, which was comparable to the Western data, but in pediatric population, response rate was only 35%. This result was an eye-opening experience for us, and based on these results, we stopped prescribing ATG plus cyclosporine to our pediatric patients and rather started to take them for haploidentical transplant if needed. So this is another example of research conducted to address the challenge of bacterial infection in febrile neutropenia patients. In this study, we tried to evaluate the availability of procalcitonin and CRP to predict bacteremia in patients with febrile neutropenia. We were interested in the study because the early detection of bacteremia could enable us to start or change antimicrobial agents. Published literatures are very much divided on the role of procalcitonin in febrile neutropenia, but in our study we were able to show that the procalcitonin is an effective biomarker to predict bacteremia in febrile neutropenia patients. Based on this study, we are conducting another study to look whether procalcitonin can predict the infection with MDR and XDR bugs. Our preliminary data shows if procalcitonin is above 30, chances of MDR and XDR isolation is very high. Our experience with hemophilia is another example of how publication in scientific journal can benefit patients in low-income countries. We all know that hemophilia is a very expensive disease, and therefore we have to rely on World Federation of Hemophilia for a donation of clotting factors for our patient. And for the last 20-25 years, World Federation of Hemophilia is donating us a huge number of clotting factors. And because of the generous donations of clotting factors, we started doing all sorts of complicated surgeries like craniotomy, arthroplasty, and excision of pseudotumors. We reported the outcome of our surgery in Hemophilia Journal, and the donor agencies were very happy with our results. And now they have started donating imicizumab or Hemlibra, a very highly effective medicine for hemophilia A. And now we have 65 hemophilia A patients receiving imicizumab as a prophylaxis. We are the only country after Sri Lanka in South Asia to put patients on imicizumab prophylaxis, and thanks to the donation. And I should really thank WFH for the donation and for having a strong faith on us. And the story doesn't stop here. We are now participating in a gene therapy trial conducted by St. Jude Children's Hospital for our hemophilia B patients. Exploring the cheaper and affordable option without compromising the efficacy of a drug is another way of tackling financial toxicity in a low-income country like Nepal. You can see in our first paper we compared efficacy of haloperidol and olanzapine in the control of chemotherapy-induced nausea and vomiting. Haloperidol was way cheaper than olanzapine when this study was designed. In our study, haloperidol was found to have comparable efficacy, and this helped us to reduce some portion of financial toxicity of our patient. In another paper, we discussed the value of using cheaper alternative medications, herbal medicines like ginger in chemotherapy-induced nausea and vomiting. Ginger is dirt cheap and can be used effectively to treat chemotherapy-induced emesis. And another way to improve a cancer care is through advocacy. In a low-income country like Nepal, low resources are allocated to the cancer treatment. And I think our publication will help government to understand the gravity of the problem and can play a pivotal role in the improvement of cancer care. So the more we publish, the more the visibility, and the more strong our data, more easier for us to convince the government to bring effective cancer care policy in the country. So coming to a bone marrow transplant, we did our first bone marrow transplant in 2012, and we published that in British Journal of Hematology. But soon we realized that there were a lot of challenges. There were a number of challenges. The number one challenge was to win the trust of referring physician and the patients. We realized this was not possible until and unless we have an international collaboration which can help us to strengthen our transplant program. Luckily, we got connected with Dr. Damiano Rondelli from UIC, and to be very honest, he has helped us in many ways. He has mentored us, taught us, and strengthened our program. His frequent visits to Nepal has helped to foster our transplant program here in Nepal, and we are very grateful to him. And this is our paper that got published in Transplantation and Cellular Therapy, and it featured how UIC has partnered with Civil Service Hospital to establish a transplant center. And these are our transplant outcomes. And if you compare that with the rest of the world, if you compare that with the high income countries, our transplant results are very much comparable to the Western data. And our transplant cost is very low and is cheapest in the world. So if you compare our transplant cost with the neighboring country, we do transplant in a much lower cost. And if you compare our transplant cost with the US, then you will be surprised, because I think in the US the transplant will cost around $250,000 to $500,000. But here in Nepal, we are able to do it in 6,000 to 13,000 US dollars. But if you look back, the establishing a transplant center in Civil Service Hospital was a very complicated procedure. And it was a kind of a nightmare for us. Right after signing MOU between UIC and Civil Service Hospital, two major catastrophic events delayed our project. Number one was the earthquake, which was devastated much of our infrastructures, and more than 10,000 people died during that earthquake. And another one, right after the earthquake, there was an Indian government embargo, and because of these two events, our transplant program got delayed for a year. Despite all these adversities, we were able to start our transplant program in August 2016, and since then we had never looked back. Our transplant program is very well recognized in the world. Last year, Lancet Hematology featured our transplant program, and we are very thankful to Lancet Hematology for this recognition. Recently, we did a study to find out socioeconomic determinants of our transplant patients. In this study, we found three factors were impacting a life after bone marrow transplant in our patients. Number one factor was a distance from civil service hospitals, from the civil service hospital. Most of them had to travel a long distance to reach hospital. Number two was a loss of caregiver job and a loss of income in the household due to a caregiver assistance to the patient. And then number three was a cost involvement in the management of post-transplant complications like cytomegalovirus and expenses related to the blood transfusion. And in the upcoming slides, I will explain how we are trying to mitigate all these complications. We also organized a global BMT conference in Kathmandu 3 years back to share our experience and to learn from our neighboring countries. Our challenges were very much comparable with their challenges in the terms of cost, infection, and lack of healthcare providers, and so on. So then came COVID in 2019, and COVID was a big challenge, but it didn't stop us either. So during COVID, because of national lockdown, patients were at risk of delayed consultation, admission, and missing scheduled chemotherapy. We didn't have a proper telemedicine service in our center that time. Therefore, we used a Viber app, which is like WhatsApp, to communicate with patient and help them for the treatment. With this approach, no one missed scheduled chemotherapy, and the patients were very happy, and they even advised us not to stop this service after COVID pandemic, because they found it very, very easy and very convenient, and they found it very convenient to talk with their treating physician. So how to move forward to overcome all these challenges? I think we need to train more and more manpower, more and more manpower. We need more hematologists. We need probably more than 50 hematologists or hematopathologists in this country, and we can do that. We can reach that number only by training a new generation of physicians. We need government support to build more and more cancer centers all over the country. We need government support to to promote our pharmaceutical industry. We also need government support to help to introduce efficient blood banking service in the country. We need more international collaborators like Dr. Damiano Rondelli to uplift our healthcare. And we also need the help of Nepali physicians who are working abroad. For example, like Dr. Gisal, for example, like Dr. Bisal Gewali. So Dr. Gewali is working very hard to improve cancer care in Nepal through his ASCO grant. Dr. Bisal and Karnal Academy of Medical Science, a university based in a rural area of Nepal, is introducing a one-year oncology program for our general practitioners in Nepal. General practitioners are the real heroes because they are usually posted in the rural areas. They are the physician, and they are the only physician in that part of the country. So one-year training of general practitioner in the field of oncology can help many patients locally and will ultimately help to improve patient outcome and reduce the financial burden of our patients. And finally, how we plan to tackle the financial burden. Well, so we have founded a U Foundation to tackle the financial burden, and we have founded it last year. U Foundation is a non-profit making organization, and it was basically a Dr. Damiano's idea. He was frustrated to see a patient paying huge amount of interest for the loans. At present, U Foundation is working with local bank and government to fund treatment expenses of acute leukemia patient, and we hope this modality will help many needy patients and no one will be deprived of treatment. I would like to thank the organizers for giving me an opportunity. If you have any questions or queries, I'll be more than happy to answer it. Thank you very much.